In this video, we'll talk about and understand the pathophysiology of left bundle branch block. Now, in normal cardiac conduction, we remember that there is the SA node that generates electricity, and the impulses will travel through the atria to the AV node, where the impulse will be delayed a little bit, and after that will be conducted to the bundle of Hess. After bundle of Hess, the impulse will travel equally down to the left bundle and the right bundle. The right bundle will go to the right ventricle, and the left bundle will go to the left ventricle, and making the contraction of the whole myocardium. Now, please note that the septum itself, the depolarization or the electricity travel within the septum itself goes from the left to the right. Okay, so it's activated the left part first, and goes to the right. Now, let's look at the heart with the EKG. Now, we remember that here's the lateral wall of the heart, and from lateral wall of the heart, we have V5, we have V6, we have lead 1 as well, and we have AVL. All of these leads are lateral leads. They are looking at the heart from here. Okay, and we remember the concept now. If the electricity is moving toward a lead, the electricity will be positive on the EKG. It will give me a positive impulse. But if the electricity is traveling away from the lead, it will give me a negative wave like this one. Okay, it will give a negative wave like this. Okay, now, so just to remember, we have lead 1, AVL, V5, V6. These are the lateral leads. And from anteriorly here, we are looking at the heart from anteriorly. We have V1, V2, and V3. They are looking at the septum and the anterior wall of the heart. Okay, so as if we are looking at the heart from two sides, anteriorly and laterally. Just remember this. Let's see what's the normal EKG recording. Now, if we look here, when the impulse travels through bundle of Hess and after that to the bundle branches, the electricity will activate the septum from the left to the right. So these electricity impulses are going away from lateral leads. So on the lateral leads, I will see a small Q wave. Okay, I will see the small Q wave here. So the small Q wave is very prominent on lateral leads, V5, V6, lead 1, and AVL. This is important. Okay, now let's suppose that this patient is having, sorry, this is V3, and let's suppose this patient is having bundle branch block, in which the left bundle is blocked. Okay, the left bundle is not working anymore. So what is going here? The electricity now, when it reaches the bundle of Hess, and it will now travel to the right bundle first, leaving the septum alone. So the septum will not depolarize from the left to the right, so the Q wave that was seen and the lateral leads will not be seen anymore. And now the electricity reached the right ventricle, and after that it will travel to the left ventricle. So as you can see here, I have this vector here, going from the right ventricle to the left ventricle. And this electricity is traveling toward the lateral leads. So on the lateral leads, I will see a positive deflection, which is the R wave. Here is the R wave. As you can see here, I can see an R wave as well. Look at lead 1 as well. Okay, so it's not all the leads will have the same thing, but like just imagine, okay? So the R wave, positive R wave will be on the lateral leads. On the anterior leads, V1, V2, and V3, look here, the vector, the electricity vector is going away from them. So by definition, they will have negative deflection, which is an S wave. So when we look at V1, we will have an S wave, V2 an S wave, and V3 will have a negative deflection. Okay, this is very important. So let's look at the criteria. Before talking about the criteria, what else is going on here? As we can see that the electricity now is not following the normal conduction system of the heart because of the block. So it is traveling within the myocardium, and this will take time to travel from the right ventricle to the left ventricle. So the Kuhr's complex duration will be, by definition, prolonged. Okay, so it will be more than 120 seconds, which is the 3 small squares. Look here, it's prolonged. Kuhr's complex is prolonged more than 3 small squares. This is really very, very important. Moreover, because the electricity is going now from the axis is now looking, if you look here, the right ventricle, the electricity is coming from the right ventricle toward the left ventricle as a huge axis. if you look at the EKG, you will find left axis deviation as well, left axis deviation as well. And moreover, you will not see a normal R wave progression in which the R wave is growing, 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 and after that it equals at V4. This will not be seen here because simply the heart is blocked. The normal pathway is blocked, so the R wave progression is not seen. And the last thing that I want to mention about this EKG here is something called appropriate discordance. The theory about this is because the depolarization is abnormal because of the block, the depolarization is abnormal, the repolarization is abnormal as well, and you will have some ST segment changes. Sometimes you will find an ST segment elevation, just like here. This is called appropriate discordance. We will talk about it like in a few seconds. All right, so let's go now and talk about the criteria for left bundle branch block. So first of all, the criteria is QRS complex duration more than 3 small squares, which is 120 milliseconds, because again, the electricity is not following the normal pathway, the electrical pathway. Number 2 is dominant S wave in V1. Okay, you need a dominant S wave again because the electricity is traveling away from V1. So you will find an S wave in V1, and you will find an R waves in the lateral leads, V5, V6, lead 1, and AVL. And moreover, you will find no Q wave in the lateral lead. These are the 4 criteria. Okay, so to have a left bundle branch block, you have to have all these 4 criteria. Sometimes you will have these associated features like left axis deviation because the axis is going to the left. Number 2 is poor R wave progression because of, again, of the block, and appropriate discordance is also seen. Now, before going there with the other things, let's have another look here. Again, the lateral leads are looking to the heart from here, and the anterior leads are looking here, and the electricity is traveling from the right ventricle to the left ventricle. Now, on the lateral leads, I will see an R wave. Sometimes this R wave will have a characteristic finding. What is that? When the right ventricle is depolarized, it will give me the upstroke, and after that it goes down a little bit. And after that, the electricity will reach the left ventricle and causing contraction, and will give me another upstroke here. So it will give me a characteristic R wave that has a notch here, which is the M wave. We call it M wave because it resembles letter M here. Okay, it's not always seen, but it can be seen, and it's actually, when you see it's indicative for bundle branch block. All right, so we talked about the criteria, and let's talk about appropriate discordance. What does that mean? Again, when we talked about the bundle branch block, we said like there is an abnormal depolarization because electricity is not following the normal electrical pathway. So if there is an abnormal depolarization, by definition, it will be followed by abnormal repolarization. And we remember that the ST and the T wave represents the repolarization period. Okay, so if the depolarization was abnormal, the repolarization will be normal, will be abnormal as well. So what is the appropriate discordance? Meaning that because of this thing is happening on the depolarization, also you can see ST segment depression or elevation. Okay, and there is some discordance between them, meaning that if you have a left bundle branch block and you can see the deep wave here, I suspect an ST segment elevation or depression, but they are, okay, just to remember this. In lead, the electricity is traveling from right ventricle to the left ventricle. So on lead V1 and V2, it is giving me the S wave. Okay, now the repolarization will be in the opposite direction because if the depolarization is going in this direction, the repolarization is going in the opposite direction by definition. Okay, so because of the depolarization was negative, the repolarization will be positive and will give me, by definition, will give some ST segment elevation. But is this a pathological ischemic elevation or not? There is a rule. It meaning that if the elevation is less than 25% of the length of the S wave, this is normal. This is called appropriate discordance. But if the ST segment elevation is way more 25% of the S wave, this will be called inappropriate discordance and indicate ischemia. So before saying that this patient has ST segment elevation or depression, you have to look for left bundle branch block and right bundle branch block. because if they have bundle branch block, by definition, they will have some ST segment elevation. And the normal appropriate discordance for ST segment elevation is only 25, less than 25% of the length of the wave. Okay, if it is more than 25%, which is 1/4, meaning that there is inappropriate discordance and you have to think about ischemia. Okay, and one more here. If you look at the V2, there is S wave, and after the S wave, you have an ST segment elevation. But this is appropriately discordant, right? Because it is less than 1/4 of the V2 of the S wave here. Now let's have a look at the lead 6 here, V6. A V6, like we know, the electricity is going toward the lead, so it will give me positive R wave. And because the repolarization is in opposite direction, it will give, after that, it will give us a negative deflection, which is the ST segment depression. And again, this is appropriate discordance because it is less than 25% of the height of the R wave. Okay, so that is what we mean about appropriate discordance. Okay, now, what are the causes of left bundle branch block? Usually, if a patient is having a left bundle branch block, this is almost always because of an organic disease. Something is happening in the heart, okay? And you have to think about ischemic heart diseases. Ischemia can damage the left bundle itself. Cardiomyopathy, especially the dilated type of cardiomyopathy. Digoxin toxicity can affect the bundle itself. Aortic stenosis because of the hypertrophy and the high pressure inside the ventricles. Hypertension, the same thing. What else? Anterior myocardial infarction, especially anterior myocardial infarction. There is a syndrome called Langer-Leaf disease in which there is infiltration of the fibrosis of the conducting system itself. Hyperkalemia can cause also left bundle branch block. So whenever you see a left bundle branch, you have to think about an organic cause in the heart. Moreover, in the past, they was once considering that if a patient is presenting with chest pain and a new left bundle branch block, they were considering this as a STEMI, ST segment elevation MI equivalent, and it was part of the criteria for thrombolysis. Now, the up-to-date data suggests that the chest pain with a new left bundle branch block is not necessarily due to ischemia. Okay, and we have too many criteria now for STEMI equivalent diagnosis. So now left bundle branch, new onset left bundle branch block does not necessarily mean ischemia. Okay, there is another concept that is called incomplete left bundle branch block, in which you have all the criteria for left bundle branch block, except for the QRS complex duration that is less than 3 small squares, meaning that there is the bundle branch, it's blocked, but not totally. So there is some electricity going through the left bundle to the left ventricle. So the QRS complex duration will be normal. Okay, but other criteria will be met, like deep S wave in V1 and V2, and R wave in the V5 and C6 with no Q waves. This is characteristic for a left bundle branch block. But if you look here, the QRS complex duration is normal. It's less than 3 small squares. So this is not a complete left bundle branch block. It's an incomplete left bundle branch block. The last thing that I want to say is some differential diagnosis. Look here. This patient is having the criteria for left bundle branch block. He's having the S wave in V1 and V2, and he has R waves in V6 here, and like even here in lead 1. And the QRS complex is broad, and there is no Q waves in V5 and C6. But there is something else in this EKG. Look here, you can see the pacing spikes. This patient is having a pacemaker. And actually, if the patient is having a right ventricular pacemaker, again, this is the heart, and let's say the patient is having a pacemaker here in the right ventricle, it will give you the similar morphology on EKG, because when the electricity is generated from the right ventricle, it will travel to the left ventricle and will have the same criteria. So the only difference between right ventricular paced rhythm and left bundle branch block is the pacing spikes. If you see the pacing spikes, meaning that this is not left bundle branch block. It's not actually left bundle branch block, but rather it is a right ventricular paced rhythm. And that's it for the left bundle branch block, and thank you.